medical practice. As you know, now we have IV cotrimoxazole as well. So I'll try to tell you where we can position both oral and IV cotrimoxazole, because with increasing drug resistance, we are going to fall back on our older drugs, which are going to come in handy for multiple indications. And I will tell you as the slides go by where and when we can position TMP SMX or Septran or cotrimoxazole in our practice. Next slide. Yeah. So both trimethoprim and sulfamethoxazole, which actually constitute TMP SMX, are weak bactericidal agents. But when they are combined together, they become extremely bactericidal. And the best synergistic concentration for TMP SMX is 1:20. So TMP 1 and SMX concentration 1:20, but the drug combination is at a fixed ratio of 1:5. That is 160 milligram of trimethoprim, 800 milligram of sulfamethoxazole in 10 ml of IV Septran. So the peak concentration is achieved, although it is in the tablet in 1:5 combination. In the tissues where it is supposed to penetrate the brain, it is supposed to penetrate the sputum, it is supposed to penetrate the middle ear, it is supposed to penetrate the bronchial secretions. There, everywhere, a concentration of 1:20 is ideal for killing the bacteria. Both the drugs are orally bioavailable, 85% bioavailability. So the dose for oral and IV TMP SMX is the same. The peak concentration is reached in 2 hours, 2 to 4 hours if you give orally, while it is in 1 hour if you give IV. So any patient who is critically ill, sick, that is where you use IV TMP SMX, while any patient who is, say, mild to moderate disease, oral TMP SMX will just do fine. Next slide. What is the spectrum of activity? We are going to restrict ourselves to only these diseases which we have pointed out, because TMP SMX is going to be helpful for Staphylococcus aureus, especially community acquired Staphylococcus aureus, and that too in patients which are coming to us with cellulitis. Secondly, TMP SMX is going to be extremely useful in urinary tract infections caused by gram-negative bacteria, and I'll tell you what are the latest IDSA guidelines for that. Then there are immunocompromised infections which are seen in immunocompromised hosts like Burkholderia cepacia, Strenotrophomonas, Serratia, Nocardia, and finally Pneumocystis jirovecii or Pneumocystis carinii, which is seen in HIV positive population causing pneumonia, and also some protozoa like Isospora. So TMP SMX has a wide spectrum of activity, and with these organisms, I'll tell you where to put TMP SMX in the management of all these organisms. Next slide. We must remember that it has no activity against Pseudomonas, no activity against Mycobacterium tuberculosis, no activity against Treponema pallidum, which causes syphilis, no activity against penicillin-resistant strep pneumoniae. So majority of our pneumonias are coming with penicillin-resistant strep pneumoniae. Septran has no role there. Rickettsial infections, people try to use it for rickettsial infections, no role there. So remember, it can be used for certain infections, it cannot be used for certain infections. So don't try and use Septran in those indications. Next slide. As I said, the dosing for oral and IV is the same. What we do is 5 ml of TMP SMX IV contains 80 milligram of TMP and 400 milligram of sulfamethoxazole. That is equivalent to one single strength tablet. So 10 ml of IV TMP SMX is equivalent to one double strength Septran tablet. It has to be reconstituted in 125 ml of 5% dextrose in water so that it can remain stable for 6 hours, and then it can be infused. Remember, at a creatinine clearance less than 30, IV Septran cannot be used. We have to reduce the dose by 50% once the creatinine clearance is between 15 to 30 ml per minute. So oral, IV, most of the time the dose remains the same. Always remember, one double strength tablet of Septran contains 160 milligram of trimethoprim and 800 milligram of sulfamethoxazole. 10 ml of IV Septran also contains the same. So you have to adjust the dose accordingly. Next slide. What are the FDA approved indications in the US for IV or oral Septran? Number one, acute exacerbation of chronic bronchitis, otitis media in pediatrics. Hardly we use it in India for the same. Traveler's diarrhea for treatment and prophylaxis, we can use it. Urinary tract infections, yes, and I will show you where TMP-SMX can be positioned for urinary tract infections. Shigellosis, we don't use it in India for Septran for shigellosis. PCP prophylaxis, PCP treatment, yes, we use it, and more immunocompromised individuals are now coming as an indication for giving Septran. So initially it started with HIV positive individuals. Now we use it for solid organ transplant, hematopoietic stem cell transplant, hematologic malignancies where you're going to cause neutropenia, rheumatologic indications where you're going to use all your biologic agents, where also to prevent PCP from happening, Septran is useful. The treatment, toxoplasmosis, both prophylaxis and treatment, TMPS used. Next slide. And then there are certain non-FDA approved indications where also we use Septran. I am going to particularly talk about Staph aureus infections of the skin, that is CA-MRSA, community acquired MRSA. I'm going to talk about isospora, I'm going to talk about melioidosis, and I'm going to talk about listeria, because all these infections are seen in India and where Septran has a definite role. Next slide. So, acute simple cystitis in adults, common infection. Many females present to us with dysuria, burning micturition, and when we diagnose them as cystitis, we ask for fever, there is no fever, there is no back pain, so there is clear, there is no chills, there is no septic look, so it's very clear that there is no pyelonephritis. It's just lower urinary tract infection, simple cystitis. Commonest organisms are E. coli, Klebsiella, and Proteus. These are the organisms which we are tackling. Next slide. And as I said, the symptoms are clear: frequency, urgency, suprapubic pain, no fever, no chills, no flank pain. And remember, many patients, actually elderly or debilitated, just present with change in mental behavior or generalized malaise or altered sensorium, and even they get diagnosed as acute simple cystitis or urinary tract infection. Remember, if the patient does not have focal urinary tract symptoms, please don't treat change in functional status, change in mental behavior, change in altered sensorium in elderly individuals as a sign of UTI. Many people make that mistake, that if a patient is elderly, above 70 years of age, comes with altered sensorium, fall, they send a urine routine. Although the patient does not have any symptom, it shows 6 to 8 pulses, they send a culture, then they say it is UTI and start treating the UTI. Remember, there is no correlation between change in mental behavior or functional status and UTI. So every elderly individual who falls at home or is slightly drowsy should not be given antibiotics for UTI unless there is urinary symptoms as well. So you have to ask whether the patient had dysuria, he had suprapubic pain, he had urgency of micturition, and only when you are sure that this altered sensorium is because of UTI, only then treat it. Otherwise, you will end up giving antibiotics to elderly individuals who don't need it, and then we will lead to antibiotic resistance, we'll need to C. difficile colitis and all other issues. So be careful. Unless there are symptoms, please do not treat asymptomatic bacteriuria or asymptomatic pyuria in elderly individuals, or for that matter, any individual. Asymptomatic bacteriuria, asymptomatic pyuria needs treatment only in 2 cases: pregnant women or patients undergoing neurosurgical procedures. Other than that, please don't send urine routine and urine culture for everybody. We see pre-surgical patients, although there are no urinary symptoms, being sent urine culture. Their culture shows something, they start treating for higher antibiotics. So please desist from that. Unless there are urinary symptoms, do not treat UTI. Next slide. What are the first line options for cystitis in females? Nitrofurantoin, TMP-SMX, and fosfomycin. These are the tablets which we give. Most of us we give nitrofurantoin at the dose of 100 mg BD for 5 days. Septran or TMP-SMX double strength 160-800 is also a good option. Look at the cure rates. Clinical trials show cure rates of almost 100% for acute simple cystitis. Remember, I am not talking about pyelonephritis. Acute simple cystitis in females. Many people, women come to us with symptoms of dysuria. You don't even need to do a urine routine. You don't even need to do a urine culture. If you are convinced it's UTI, you can start any of these 3 tablets and the patient will be fine. Next slide. So It is very clear. Simple cystitis is dysuria, frequency, urgency. If there is fever, there is chills, there is flank pain, there is pelvic pain, there is costovertebral tenderness, you are dealing with complicated UTI or you are dealing with pyelonephritis, the treatment is completely different. Simple cystitis, the treatment is completely different. For simple cystitis in females, we can give nitrofurantoin or Septran. So this is the first indication where you can use Septran oral for women who present to you with acute simple cystitis. Next slide. So the dose is 1 double strength tablet twice a day, and you can next slide. So what about resistance? Resistance is developing. If in your locality more than 20% resistance is there to TMP-SMX, then please do not use TMP-SMX for acute simple cystitis. Fortunately, in India, we don't have that much amount of resistance. The E. coli which we find in our urine cultures is sensitive to nitrofurantoin. It is sensitive to Septran. We should use it. And instead of giving higher antibiotics, we can use, and I'll show you in further slides, the IDSA guidelines are also saying the same, and give lower antibiotics which concentrate well in the urine. Remember, TMP-SMX concentrates in the urine very well. So we can use TMP-SMX and NIFT-SR for patients who have acute simple cystitis in females. Next slide. There is another drug, pivmecylinum, and this was the first drug which was published by IDSA just this last month, saying that in addition to Septran, in addition to NIFT-SR, in addition to fosfomycin single dose 3 gram, we can also now use pivmecylinum as treatment for acute simple cystitis. Although it is not available in India, it will get available in India soon. Next slide. What about males? It's always said that any urinary tract infection in male is a complicated urinary tract infection, but it is not so. Unless a male has neurogenic bladder or has severe comorbidities, any patient coming to you, although he is a young male, coming to you with dysuria and urgency, should also be treated as acute simple cystitis. Yes, of course, if he has fever, back pain, then he should be treated as pyelonephritis. And the treatment for males is similar as females, acute simple cystitis. Here also in India, we can use TMP-SMX double strength tablet twice a day for treatment of acute simple cystitis. Next slide. As I said, males have another problem. Sometimes the infection can go to the prostate. And even if you treat the infection, the patient can get repeated urinary tract infection. If the person keeps on getting urinary tract infection, or by giving tablets, if he's not feeling better, remember he might be having a prostatitis or a prostatic abscess. It might require a PR examination, and painful prostate can be told to you by a surgeon. And remember, nitrofurantoin or fosfomycin do not concentrate in the prostate. So if the patient is having prostatitis, then there are only two drugs which we can give to patients who have acute simple cystitis plus prostatitis. One is TMP-SMX, 1 double strength tablet twice a day, which needs to be given for 3 to 6 weeks. Remember, for simple cystitis, you can give the treatment for 5 to 7 days. But for cystitis and prostatitis, you need treatment for almost 3 to 6 weeks, because these are the drugs which will concentrate in the prostate, and these are the drugs which will cure the prostate, which will treat the prostatitis. The other drug which can be used is fluoroquinolones. Ciprofloxacin or levofloxacin can be given for 4 to 6 weeks for treatment of prostatic abscess or prostatitis. Next slide. So, as I said, if the patient is not improving within 48 to 72 hours, rule out prostatitis. Also rule out pyelonephritis, because as I said, any UTI in males, you should always have at the back of your mind that this could be complicated UTI. You should do a sonography, rule out a renal calculus disease, rule out a stricture, rule out a hydronephrosis. If the patient is not improving in NIFT or Septran, you might be dealing with a complicated pyelonephritis, and you should investigate in that matter. Next slide. So why are we worried about complicated urinary tract infections? Because scarily enough, we are now seeing more and more patients coming to you with cystitis also of organisms which are producing ESBLs. So many of the residents here must have heard, you have seen urine culture reports where the patient has come to you, has just plain cystitis, he has dysuria, he has dysuria, he has excess frequency of mixed urine. And when a urine culture is sent, it shows E. coli, and in bracket it is ESBL producing, or Klebsiella pneumoniae bracket ESBL producing. and then suddenly everybody starts getting worked up and they start giving meropenem. What is ESBL? It is extended spectrum beta lactamase. The organisms are the same which cause simple cystitis, E. coli, Klebsiella. What does ESBL do? It knocks off ceftriaxone, it knocks off ceftazidime, it might knock off cefepime, it might knock off piperacillin tazobactam as well. And then meropenem remains the only option. So what happens if cystitis is developed because of ESBL? Do we directly jump to meropenem? Every patient who just walks in with, or any female who comes to you with cystitis, or say increased frequency of micturition or dysuria, and a urine culture shows ESBL producing E. coli, do you suddenly start giving meropenem to everybody? Next slide. What does the IDSA guidelines say? No. If you have uncomplicated cystitis, although the urine culture is showing ESBL producing E. coli, the treatment remains nitrofurantoin and TMP-SMX. Remember, extended spectrum beta lactamase is against beta lactams. Septran and nitrofurantoin are not beta lactams. So ESBL is not going to destroy your nitrofurantoin. ESBL is not going to destroy your TMP-SMX. So for simple uncomplicated cystitis, although the organism is ESBL producing, the treatment of choice is nitrofurantoin and TMP-SMX only. So this should be used. You should not get worried about whether it is showing ESBL. Yes, if there is pyelonephritis, the treatment differs. But for simple cystitis, many times I get urine culture reports where the patient has just simple cystitis, just dysuria, just frequency. The culture is showing ESBL. Suddenly everybody starts giving meropenem. No, that is not antimicrobial stewardship. We have to save meropenem for the last. These drugs work fine for cystitis. Next slide. What about pyelonephritis? So you have a pyelonephritis, the USG shows pyelonephritis, patients have fever, and the urine culture shows ESBL E. coli. Yes, then definitely the carbapenems are treatment of choice, but even see the IDSA guidelines, they have still kept fluoroquinolones and TMP-SMX as preferred options for pyelonephritis. So if you have a pyelonephritis where urine culture is showing ESBL E. coli, extended spectrum beta lactamase producing, then still after giving meropenem, after giving ertapenem, after giving imipenem, once the source control is done, the patient is fine, you need to treat the pyelonephritis for 14 days. After 3 or 4 days, you can scale down to Septran or scale down to ciprofloxacin and then continue the treatment for the next 14 days. So remember, even for pyelonephritis because of ESBL, meropenem first or followed by TMP-SMX, or if the patient is very stable, you can also start IV Septran in these cases. Once the patient improves, shift him to oral Septran over 14 days. So remember, TMP-SMX can be used for ESBL pyelonephritis as well. Every ESBL pyelonephritis does not need meropenem for 14 days. You can give ertapenem or meropenem for 7 days and then scale down to Septran or ciprofloxacin for the next 7 days once the patient is medically or clinically stable. Next slide. What about ESBL infection outside the urinary tract? Say you have a pneumonia caused because of ESBL, or say a bloodstream infection because of ESBL. Remember, a treatment of choice remains carbapenem. The carbapenem has to be given till the patient becomes hemodynamically stable. Once the appropriate clinical response is achieved, once the NORAD dopamine has been stopped, once the ventilator has been removed, whether it is pneumonia or bacteremia, once the intensivist is sure that the person is out of sepsis and you have to give treatment for total 14 days, then you can scale down to oral fluoroquinolones or TMP-SMX here as well. So for ESBL, whether it is cystitis, you can give upfront TMP-SMX. For pyelonephritis, upfront carbapenem followed by scale down to levofloxacin or TMP-SMX. For bacteremia, pneumonia, intra-abdominal infections, upfront carbapenem and then shift back to fluoroquinolones or TMP-SMX once clinical cure or removal from sepsis has been achieved. So remember, TMP-SMX, our old friend, can be used for multiple indications as I have told you here. Next slide. So the step down therapy, as I very clearly said, it is not to be given upfront, but once you have a culture which shows that levofloxacin or TMP-SMX is sensitive, the E. coli is sensitive, patient is hemodynamically stable, there is no NORAD requirement, there is no other requirement, the patient is out of ventilator, and if you have concerns about intestinal absorption, you can give IV Septran If you have no concerns about intestinal absorption, then you can give oral ceftriaxone and oral fluoroquinolones as step-down therapy for ESBL infections as well. Next slide. Next slide. Next slide. What about carbapenemase producing enterobacteria? So I talked about ESBL, but there are other carbapenemases which are produced, which are even more scary than ESBL. The extended spectrum beta lactamase only knocks off your ceftriaxone, ceftazidime, but spares your, it can knock off your piptas sometimes, it can knock off your cefepime sometimes, but it will still spare your meropenem, spare your imipenem, spare your ertapenem. But as you go ahead, more and more enterobacteria are now producing what I call as carbapenemases. There are multiple classes. A, C, and D are serine carbapenemases. Class B is zinc carbapenemase, and it is called as metallobeta-lactamase. Remember, the most common class A carbapenemase is Klebsiella pneumoniae carbapenemase, or you known as KPC. So you might have urine culture reports saying Klebsiella pneumoniae isolated KPC producing, that is a carbapenemase producing. Or you might have a urine culture shows Klebsiella pneumoniae NDM producing, New Delhi metallobeta-lactamase 1 producing. So that is class B beta-lactamase, and OXA is class D carbapenemase. So these are the ones which will make our job even more tougher. Next slide. Why are these carbapenemase producing bacteria seen in our ICUs? Number one, because we are now having more immunocompromised population. So we have diabetes, we have malignancy, we have immunocompromised, we have immunosuppressive agents used left, right, and center, we have organ transplantation, then we have patients on mechanical ventilation, we have patients on indwelling urinary or venous catheters. Remember, there are patients who are staying in the ICU for a very long time, or patients are staying in step-down units for a very long time. There is where the carbapenemase producing bacterial infections can be seen. Remember the last point, medical care in India or Pakistan today is a risk factor for accumulating NDM1 beta-lactamase. So we have been useful, we have been becoming now famous for something which we have given to the whole world, New Delhi beta-lactamase 1. Next slide. So what are the preferred antibiotics? So a patient comes to you, dysuria, you increase frequency of micturition, and the patient says the culture shows E. coli, KPC producing, or Klebsiella, KPC producing. What are you going to do? Are you suddenly going to jump to meropenem or jump to further agents? No. The treatment of choice remains ciprofloxacin, TMP-SFX, nitrofurantoin. So don't be alarmed by urine culture reports. We are going to treat the patient. First, rule out whether there is cystitis or pyelonephritis. If it's just cystitis, you can get away with oral therapy for carbapenemase producing bacteria like KPC producing bacteria as well. So remember, uncomplicated cystitis caused by CRE, no pyelonephritis. The patient shows KPC producing or NDM producing, but sensitive to ciprofloxacin, sensitive to TMP-SMX, sensitive to Nifty-SR. Remember, use these drugs first. These drugs are not beta-lactamases. These are not beta-lactams. They cannot be destroyed by beta-lactamases. They cannot be destroyed by carbapenemases. They require other mechanisms for resistance. So if they are sensitive, go ahead, use it. Don't worry about the rest. Next slide. What happens if there is pyelonephritis? Remember, you can check again. IDSA clearly says if there is carbapenem resistance, but the patient is sensitive to ciprofloxacin, sensitive to TMP-SMX, use these options. And in pyelonephritis, you can use IV levofloxacin, IV TMP-SMX, because it leads to fast concentration and destruction of the bacteria. So even for pyelonephritis, if there is CRE or carbapenemase producing Enterobacteriaceae, even if there is meropenem or imipenem resistance, and if levofloxacin or TMP-SMX are sensitive, you can use it, or you can jump to what we use today, that is ceftazidime avibactam. So remember, ceftazidime avibactam or Zavicefta is now the treatment of choice for CRE. For pyelonephritis, we can definitely use it. But if you have a lower option, you can use it once the patient improves. So if you have a pyelonephritis, it shows KPC, you put the patient on Zavicefta, the patient improves, the fever goes down, you are clinically stable, you know you have to treat for 14 days, you look back at the culture report, the patient says, sir, I can't keep on taking this IV for a long time. You see that the Ceftriaxone is sensitive. Then after 7 days, you can stop the Zavicefta and go back to oral Septran for the next 7 days and finish the course of pyelonephritis. So remember, even for CRE producing pyelonephritis, ciprofloxacin and TMP-SMS, if sensitive, I'm not saying if it is resistant, then it cannot be used. If it is Septran resistant, if it's Ciplox resistant, if it is meropenem resistant, then you have to use ceftazidime-avibactam. There is no choice. But if it is available, then maybe you can upfront use ceftazidime-avibactam when the patient is in sepsis, when the patient is in the ICU. You remove him from the ICU, better, the patient is better, there is no NORAD requirement. You can go back to Septran or ciprofloxacin to complete the treatment of pyelonephritis. Next slide. So remember the dose, it is very clear, 8 to 12 mg per kg of the trimethoprim component. So if it is 10 mg per kg and if it's a 60 kg man, you have to give 600 milligram of trimethoprim per day in divided doses. Remember, 10 ml contains 160 milligram. So you have to use maybe 4 times. So 10 ml, 10 ml, 10 ml, 10 ml IV 6 hourly can be used. So remember, the same dose is orally as well. So the 10 ml of IV Septran is equivalent to 1 DS tablet. So if you want to give a DS tablet, you give 1 tablet 4 times a day. Or if you want to use IV Septran, you can use 10 ml IV 4 times a day. The same thing will be achieved. Next slide. Outside the urinary tract, if you have CRE resistant to both ertapenem and meropenem, here you don't use Septran. So outside the urinary tract, the role of Septran is very, very limited. There you go back to your ceftazidime-avibactam for treatment of KPC, ceftazidime-avibactam for treatment of OXA48, and ceftazidime-avibactam plus aztreonam for treatment of NDM beta-lactamase organisms. So outside the urinary tract, the role of TMP-SMX is very, very low. Next slide. What about recurrent UTI? So many patients come to us with UTI 3 times a year, 4 times a year, 5 times a year, and they are worried about that dysuria and increased frequency which they keep on getting. So what do they do? Next slide. IDSA came out with clear-cut guidelines, and they have included daily Septran taken single strength tablet, 40 milligram of trimethoprim and 200 half a tablet of single strength tablet, which can be taken for almost a year. So in any female who gets more than 3 episodes of UTI in a year, who is really worried, she is postmenopausal, you have tried your hydration, you have tried your vaginal estrogen cream, but she keeps on, you have tried your cranberry supplements, and you still get recurrent UTI, then you can give prolonged prophylaxis with oral Septran, half single strength tablet daily for almost 6 months to a year, and these episodes of recurrent UTI do come down. We can also use NIFTY-SR. So for recurrent UTI as well, Septran and nitrofurantoin have a huge role. Next slide. What about skin and soft tissue infections? So I have talked about urinary tract infections where Septran, as you know, has a huge role in cystitis. Even though there is ESBL, even though there is KPC, even though there is NDM, even though there is OXA48, if the culture shows sensitivity, you can use it. Even for pyelonephritis, you can use it as a step-down therapy if the sensitivity is there. What about skin and soft tissue infections? Next slide. Next slide. Next slide, please. I think we have lost. We will just wait for some time.
Yeah, unfortunately, we have lost the connection. Just give me a second, sir.
No problem. Waiting. I'll till then I'll try to answer the question. Dr. Sharma has asked how about hemodynamically unstable ESBLs. I've already said that if he's hemodynamically unstable, you don't need to give IV Septran or oral Septran. First give carbapenem, stabilize the patient, take him out of the ICU, and then you can scale down to oral Septran. Similarly with stents and urinary calculi, if you have urine culture which shows ESBL, we still use carbapenem because it's a complicated UTI, and then we can come down. I think you need to go back. You have gone 3-4 slides ahead.
Just 12%.
You're going ahead. I think you go back.
Yes, sir. Just give me.
Go back. Go back. Yeah. So we will talk about skin and soft tissue infections and where MRSA can fit in over there. Next slide. So the most common causes of cellulitis or erysipelas in infections in humans is only 3 organisms. Number 1, it's Streptococcus, and number 2, it's Staphylococcus, either MSSA, methicillin sensitive, or MRSA, methicillin resistant. Remember, this MRSA is community acquired. It's not hospital acquired MRSA. So it is known as CA MRSA, community acquired MRSA. So you need to worry about only these 3 organisms. One is Streptococcus pyogenes. Number 2, beta hemolytic streptococci. Number 3, MSSA. Number 4, MRSA. Next slide. Next slide.
So unfortunately, again, some network issue. Just hold for a second.
Thank you. So when do you suspect that there is MRSA infection in cellulitis or MRSA infections in erysipelas? Recent hospitalization or residence in a long-term care facility, or if the patient is diabetic and on hemodialysis, or he is HIV positive, he is injection drug abuser, he is homeless, or he is a man who has sex with men, or he has antibiotic use in the prior 6 months. These are the risk factors. Or he is incarcerated, he is a prisoner, he is in military service, or he stays in a hostel and then comes to you with cellulitis, or comes to you with redness of the limb, throbbing pain in the limb, then you should suspect that this cellulitis is because of MRSA and not because of Streptococcus or MSSA. Next slide. So this is a general outlook of how to treat with cellulitis. Remember, if you have cellulitis and it shows pus in the limb, or if the patient is having fever, or if the patient is having leukocytosis, or if the patient is having hemodynamic instability, more of the time it is MRSA. So any pustular lesions on the limb or any pus in a cellulitis is more because of MRSA. Normal cellulitis where the limb is just warm, red and throbbing, more likely it is because of Streptococcus and because of MSSA. So for Streptococcus and MSSA, you don't need Septran, you don't need clindamycin. All you need is just flucloxacillin, which is simple treatment for both Streptococci and MSSA. Only if you are suspecting MRSA, then you use drugs like oral Septran, oral clindamycin, or oral doxycycline. So for any patient who has cellulitis because of MRSA, there you use oral Septran, there you use oral doxycycline, there you use oral clindamycin. But if the patient has systemic toxicity, if the patient has high-grade fever, if he has hypotension, there you don't need the oral drugs. There you use IV drugs like vancomycin or daptomycin, where you suspect MRSA, or cefazolin or IV flucloxacillin, where you suspect MSSA or Streptococci. So you have to decide once the patient comes to you. What happens is, any patient who comes to you with cellulitis, we end up giving IV vancomycin or tablet linezolid or IV teicoplanin. That should not happen. Once cellulitis comes to you, just rule out whether he has risk factors for MRSA or no. If he is not HIV positive, if he does not have pustular lesions in the cellulitis, if he does not have high-grade fever, if he does not have high leukocytosis, if he is not having NORAD or DOPA requirement, this could just be plain MSSA or Streptococci, you can get away by giving oral flucloxacillin. Yes, you do a debridement, do a source control, send a culture. If the culture shows MSSA or streptococci, you can give just flucloxacillin for treatment. If it shows MRSA, then you can give clindamycin, you can give doxycycline, you can give Septran. If he is really having high-grade fever, he's having hypotension, if he is in sepsis, then you can give IV vancomycin for MRSA. Or if you suspect it is just MSSA or streptococci, or the culture or blood culture comes as MSSA or streptococci, then you can give IV flucloxacillin also, or IV cefazolin, and get better. So every cellulitis does not require vancomycin. Every cellulitis does not require clindamycin. You have to make it a difference. MSSA and streptococci, different treatment. MRSA, separate treatment. Next slide. So you can see if it's just CA MRSA and the patient is not hemodynamically unstable, he's just walking into your OPD, he is diabetic, he has pustular cellulitis, you can give clindamycin or you can give Septran. The problem with clindamycin is it causes pseudomembranous colitis, C. difficile colitis, patient can come with diarrhea. In that case, you can use Septran, 1 tablet, DS tablet twice a day as well. So this is another indication for Septran in your OPD. For IPD, yes, IV vancomycin if the patient is hemodynamically unstable. Next slide. As I already mentioned, IV vancomycin or IV linezolid. So only if the patient has pustular cellulitis, high-grade fever, patient might land up in ICU, patient has leukocytosis, he's hemodynamically unstable, he's having high-grade fever with chills, then only use vancomycin. But here, even plain simple cellulitis where the patient just walks in your OPD also ends up getting linezolid, ends up getting Dalcinex. No, it should not happen. Try to rule out what is causing it. Next slide. So very clear, TMP-SMX for cellulitis, especially MRSA cellulitis, even for MSSA cellulitis, even for streptococcal cellulitis, Septran will be helpful. So if you give Septran and the person comes as MSSA or streptococci, you're not wrong. Similarly with clindamycin, it will work against streptococci, MSSA, MRSA, all three. Remember, amoxicillin can also be used, doxycycline can also be used, but doxycycline provides coverage for Staph aureus but does not cover for MSSA. So if you are dealing with MSSA, you might require some other treatment as well. So look at the cure rates. Septran has almost cure rates of 76 to 90%. So we always try to shun the simpler tablets and go for IV injections. Simpler tablets also have 76 to 78% cure rates for cellulitis. Next slide. Dosage I have already mentioned. Next slide. What about traveler's diarrhea? Many foreigners who come to India and develop diarrhea take Septran tablet twice a day for 5 days. Shigellosis also, they take 1 DS tablet for 5 days. But in India, we normally don't use Septran for traveler's diarrhea or for shigellosis because the Shigella in India sometimes is resistant to these antibiotics. We use higher antibiotics for the same. Next slide. Then the most common Pneumocystis carinii pneumonia. Next slide. It's now classified as a fungus. It is seen now more in non-HIV infected population. As I said, hematologic malignancies, organ transplant, your rheumatologic conditions where Septran prophylaxis is not given, patients can present to you with subacute onset of progressive dyspnea, fever, non-productive cough and chest discomfort. Many times if you examine the patient, there are no rhonchi, no creps, and the patient the X-ray also might be normal. Next slide. So today Pneumocystis carinii pneumonia was initially seen in advanced HIV, but now it is seen in solid tumors, hematologic malignancies, primary immunodeficiencies, autoimmune conditions which are on immunomodulating therapies, and today it is more seen in non-HIV population. In contrast to PCP in HIV, the disease course in immunocompromised group is characterized by abrupt onset of respiratory failure, rapid deterioration, high mortality rate. So mortality rate is less than 10% for PCP in HIV, but can be as high as 50% in PCP in non-HIV population, and although has lower fungal burdens, can have very high mortality. So diagnosing PCP is now becoming a challenge in patients who are non-HIV, immunocompromised, and come to you with breathlessness, subacute onset. Next slide. So if you do an blood gas, many times you find that the PO2 is less than 60, severe pneumonia. X-ray in early diseases is normal. So PCP, the whole thing is many times the patient will come with breathlessness. He will say, I'm feeling breathless on exertion. The breathlessness is there since last 1 month. But when I do an X-ray, the X-ray comes normal. Remember, a normal X-ray does not rule out PCP. Next slide. So what you have to do is what is called as the CT scan. The HR CT scan has a sensitivity of almost 99%. It will show you an interstitial pneumonia, which is peribronchial central pneumonia. If you do a bronchoscopy, the BAL will also lead to identification of the cysts of Pneumocystis carinii, and you need to use either GIMSA or Wright stain or gomodomethanamine silver stain for diagnosis of PCP. Next slide. There are now PCRs available, and now quantitative PCR or even conventional PCRs are available, which we can subject our BAL samples, and the sensitivity is pretty high. If you look at it, the sensitivity is almost 97% for a BAL sample. For induced sputum also it is almost 98%, and for upper respiratory tract samples also it is around 89%. So now we don't need to be dependent on just doing a GIMSA stain or doing a BAL GIMSA stain. We can also do a BAL PCR for PCP and diagnose PCP early. Next slide. Next slide. So you can see here in early PCP, the X-ray is normal. Next, if the advanced PCP, you will see perihilar interstitial shadows like a bat's wing appearance. It might resemble pulmonary edema, but if you do a HRCT, next slide, you will find interstitial pneumonia, ground glass opacities all over. Next slide. See here, ground glass opacities. Next slide. Next slide. Next slide. Yeah. So treatment is TMP-SMX. That is the treatment of choice. And here, if the patient is very severely ill, the patient can be on a ventilator, patient can be on HFNO, patient can be on NIV. That is where IV Septran is of humongous benefit, because it will lead to early drug levels. Patients will start feeling better early. In addition to Septran, we also have to use steroids. The normal dose of Septran tablet is a DS tablet, 2 tablets thrice a day. Similarly, if it is IV Septran, you will have to require 10 ml of TMP-SMX thrice a day or 4 times a day if the patient is overweight. In addition, we'll use steroids. Normal dose is oral Omnacortil of 40 mg BD, and then taper. If you don't have Omnacortil, then the IV methylprednisolone, 75% of the oral prednisolone dose has to be used. If the patient has allergy to Septran, which many people can have, then clindamycin primaquine is an acceptable alternative and can be used. Remember, if the person is HIV positive, within 14 days he has to go on antiretroviral therapy, and as long as the patient is having a CD4 less than 200, secondary prophylaxis with oral Septran has to be given till his CD4 goes to more than 200 and viral load less than 20 copies. Next slide. As I said, toxicity can be there. Stevens-Johnson syndrome can happen. Rash can happen because it's a sulfur drug. If you use clindamycin primaquine, again, primaquine is a bone marrow suppressant. It can cause anemia, and clindamycin can cause fever and rash. Next slide. What happens if you give Septran, IV Septran, and the patient does not improve in around 4 days? So we have to wait for maximum 4 to 5 days. You have diagnosis is clear, PCP is diagnosed, whether he is HIV or non-HIV doesn't matter. You give IV Septran or oral Septran, high dose for 4 days. If the patient doesn't improve, then you have to take it as a treatment failure. And on top of Septran, you have to add IV clindamycin and primaquine. So the Septran will continue. On top of that alternative regimen, clindamycin plus primaquine has to be added. If steroids have not been given, use steroids. Some people have also tried caspofungin, micafungin, and anidulafungin, which are antifungal drugs, because remember, Pneumocystis jirovecii is now classified as a fungus, have been tried, and some patients have improved on caspofungin as well. So if the first treatment of choice remains Septran, if Septran doesn't help, the patient can be given clindamycin primaquine on top of Septran, or you can even try echinocandin for the same. Next slide. What about chronic diarrhea in HIV positive patients? Many patients come to you with chronic diarrhea. Next slide. The chronic diarrhea can be cryptosporidial, where you use Nisonide. Next slide. But sometimes chronic diarrhea can also come as isospora, and that is where you use Septran, one Septran DS tablet 4 times a day for 10 days. So here also Septran can be given if the patient has severe diarrhea, severe exsanguination, he cannot tolerate orally, you don't know whether the tablet will be absorbed orally, you can try IV Septran also for such patients who are having cachexia because of severe diarrhea and early initiation of antiretroviral therapy. Next slide. Chronic diarrhea can be because of microsporidiasis also, where you give albendazole in addition to ART. So everywhere where the patient develops chronic diarrhea, once you initiate Nisonide, once you initiate IV Septran, once you initiate albendazole, ART has to start within the next 7 days because the patient needs virologic suppression. Next slide. What about the next organism, Stenotrophomonas maltophilia? This organism is a gram-negative bacillus. It is now increasingly seen in our ICUs, increasingly seen in patients who are on a ventilator, who are immunocompromised, and has a very high mortality. Why is it important? Because your patient is going to be on a ventilator, he is going to have underlying immunosuppression, underlying malignancy, he is going to have a central venous catheter, it is going to have a Foley's catheter, he must have already been exposed to broad spectrum antibiotics, he might have had infection earlier, he might have got meropenem earlier. Then this organism starts growing. And Stenotrophomonas maltophilia is an organism which can produce 2 penicillinase, one L1 penicillinase and L2 cephalosporinase, which can target many of your organisms. Next slide. So it can cause pneumonia, especially in immunocompromised patients. It can cause fatal hemorrhagic pneumonia. It is a colonizer. So once the patient is, you send an ET culture and it grows Stenotrophomonas maltophilia, first rule out a pneumonia versus colonization. Once you rule out, once there is a pneumonia, once there is leukocytosis, once the patient has fever, the patient is ventilator requirement is increasing, where you know that this is pneumonia because of Stenotrophomonas, it needs treatment. If the blood culture grows Stenotrophomonas, it needs treatment. Remember, it is a biofilm forming organism. It will grow on a central venous catheter and cause bacteremia. So in immunocompromised individuals, it is an emerging ICU bug. It needs to be taken care of. Next slide. What is the treatment? Mild infection, you can give Septran oral. The dose is around 10 mg per kg, or you can give oral minocycline as well. So it's just simple pneumonia. Patient is hemodynamically stable. You can give minocycline, trimethoprim sulfamethoxazole, or levofloxacin. Next slide. But in severe infection, IV is preferred, and we give combination therapy, Septran plus minocycline. So remember, if Stenotrophomonas grows in your culture, there is hospital-acquired pneumonia, there is hospital-acquired bacteremia, then the treatment is IV Septran plus minocycline. There is no other treatment. This is the treatment of choice. Next slide. So, next slide. So, as I said, general approach for treatment, IDSA makes it clear. Treatment of choice is TMP-SMX, minocycline, or levofloxacin. If the patient is on a ventilator, IV Septran plus IV minocycline or levofloxacin should be the treatment of choice. Next slide. However, if the patient has, if the Stenotrophomonas is producing carbapenemase, if is producing penicillinase, then the treatment of choice is ceftazidime avibactam plus aztreonam. So giving IV Septran, giving IV minocycline, if the patient is not improving, the pneumonia is worsening, then the treatment of choice is to jump directly to ceftazidime avibactam plus aztreonam. No meropenem, no piptas, no cefepime, nothing will work. Either Septran, minocycline, levofloxacin, or ceftazidime avibactam plus aztreonam, because this penicillinase, this carbapenemase will destroy all piptas, destroy all cefepime, destroy all meropenem. Only ceftazidime avibactam plus aztreonam will work. So for Stenotrophomonas, remember, if that is grown in culture, your microbiologist says there is pneumonia with culture growing Stenotrophomonas, you know what is to be done. Next slide. Next slide. What about nocardia? Again, another opportunistic infection which occurs in immunocompromised population. It is a gram-positive delicate filamentous branching rods. Next slide. See this. This is one of my patients who came to me who was advanced HIV and had pneumonia. And you can see here branching gram-positive rods typical of nocardia. Next slide. See, gram-positive rods lined with each other, branching, typical of nocardia. Next slide. So it can be seen in HIV positive individuals. Again, it can be seen those who are on glucocorticoids, who are on calcineurin inhibitors, those who are on organ transplant, it is a immunocompromised patient's disease. Next slide. And remember, 80% of the cases will come to you with pneumonia, but 50% of them will disseminate to the CNS. So you can have patients having asymptomatic CNS infection, asymptomatic CNS abscess, which is very common in nocardia. So if you have a immunocompromised individual who has a pneumonia, you have done a CT scan, you have sent a sputum, the sputum has shown branching gram-positive rods, the microbiologist said it is nocardia. Every patient should undergo an MRI brain, irrespective of whether he is just having a pneumonia, because he will be having, in 50% of the cases, a cerebral abscess as well. Next slide. See this pneumonia. This is one of my patients who was advanced HIV disease, came to me with lower zone pneumonia bilaterally. Next slide. Look at the CT scan. There is cavitation, there is abscess formation, very typical of nocardia pneumonia. Next slide. Next slide. You can see here multiple infections. Next slide. Next slide. So if it's mild to moderate pulmonary disease, the treatment is just give Septran. That's all. If the patient is hemodynamically stable, there is no hypoxia, there is no CNS problem, just having nocardia pneumonia, Septran is the treatment of choice. Next slide. However, if there is severe, next slide. However, if there is severe infection, just like this patient who was HIV positive, advanced HIV, bilateral pneumonia, nocardia positive, then the treatment of choice is TMP-SMX IV plus amikacin. So we have to give one more drug, severe infection, pneumonia or bacteremia, or maybe empyema, it can cause empyema as well. Then the treatment is Septran IV plus amikacin, or you can use imipenem plus amikacin. In cases of cerebral abscess, however, the treatment is Septran plus imipenem plus amikacin. So if you have neurologic disease because of nocardia, the treatment of choice is Septran plus imipenem plus amikacin. If it's just severe pneumonia, it is Septran plus amikacin. If it's not severe pneumonia, it's just mild pneumonia, the treatment can be only Septran. So for nocardia also, remember, you don't need to jump to meropenem, you don't need to jump to piptaz. Simple Septran plus amikacin, Septran plus imipenem, Septran plus imipenem plus amikacin will take care. Next slide. Next slide. And remember, after giving the treatment for almost 3 to 6 weeks, you have to step down to an oral therapy which contains either Septran or minocycline or coamoxiclav, sometimes in combination, which might require to be given for almost 6 to 12 months. So this treatment is long. Once you have a nocardia patient, you have to treat for almost 12 months if it's CNS nocardia, almost 6 months if it is pulmonary nocardia. So it's a long treatment because it can disseminate to the CNS and it can relapse very fast. So these two things you have to remember while treating nocardia. Next slide. Secondary prophylaxis. Once you have treated the nocardia, many patients go on indefinite secondary prophylaxis of Septran. So we can go on indefinite secondary prophylaxis of Septran for life if it is severe nocardia pneumonia or severe nocardia infection of the brain. Next slide. What about Serratia? I will run through my slides now because I'm just coming to the end. This is again a new ICU bug, Serratia mascarensis. Again, it can cause UTI, pneumonia, bloodstream infection. It most commonly can also cause CNS infections and infect ventriculoperitoneal shunts. It's a hospital-acquired pathogen. Next slide. Again, it has intrinsic resistance to multiple organisms and it produces which is called as AMP-C beta-lactamase or class C beta-lactamase or class C carbapenemase. Next slide. The treatment, if it is just simple UTI, you can give TMP-SMX is the treatment of choice or give fluoroquinolones. Next slide. What about if you have a UTI, if you have any organism which is AMP-C producing and causes UTI, the treatment is again simple cystitis, nitrofurantoin or Septran. Next slide. If it is severe infections, if it is CNS infection because of Serratia, where you know that AMP-C resistance will be there, then you have to use either meropenem or cefepime. We can give 2 gram 8 hourly, and after that we can step down to oral Septran. So even in Serratia, if it is just plain cystitis, you can use oral Septran. If it is CNS infection, give meropenem or cefepime and then step down to TMP-SMX. So another organism where you can use TMP-SMX upfront. Next slide. Next slide. What about listeria? And as you know, listeria is present in raw milk, raw food, and many elderly individuals who end up eating raw milk or raw food ultimately get listeriosis, most commonly CNS infections seen in elderly individuals who get meningitis. Next slide. Next slide. And remember that if you get meningoencephalitis, then the treatment of choice is AMP-Genta or meropenem plus Genta. And if AMP cannot be given, or because the patient has a beta-lactam allergy, you can use TMP-SMX. So for listeria, meningoencephalitis, also you can use TMP-SMX. Next slide. What about melioidosis? Again, it is quite common in India. It is caused by Burkholderia pseudomallei. Next slide. Again, in immunocompromised individuals, can cause pneumonia and it can mimic tuberculosis. Next slide. See this X-ray looks very like tuberculosis, but when we sent it for culture, it grew Burkholderia pseudomallei and did not grow Mycobacterium tuberculosis. So in endemic individuals, especially south of India, is endemic for melioidosis, and you should suspect melioidosis when you are treating pulmonary tuberculosis. Next slide. Again, blood culture is the treatment of choice, and these are gram-negative organisms who have bipolar staining and give a safety pin appearance. So your microbiologist will call you saying, sir, this is a gram-negative bacillus and has safety pin appearance, and the culture is growing Burkholderia pseudomallei. You know you are dealing with melioidosis and you are not dealing with tuberculosis. Next slide. Again, if you are non-critically, if it's critically ill patients, if it's CNS involvement, if it's very much lung involvement, then you give ceftazidime or meropenem as the drug of choice, and adjunctive therapy, we give Septran. So in addition to ceftazidime, in addition to meropenem, for non-pulmonary focal infections, we do give Septran. So in addition to ceftazidime plus Septran or meropenem plus Septran can be given for melioidosis. Next slide. Subsequent, once the patient's pneumonia has reduced, you have given ceftazidime, you have given meropenem, you can continue giving oral TMP-SMX, and you have to give it for a very long time because it can relapse. The overall mortality has come down to around 10%. So by giving ceftazidime or meropenem in pulmonary melioidosis or CNS melioidosis and then stepping down to TMP-SMX, we can continue for a long time and eradicate the patient, eradicate the melioidosis. Next slide. So remember, first 2 weeks to 3 weeks, you give ceftazidime or meropenem. And if it's CNS infection, you give 8 weeks of meropenem or 8 weeks of ceftazidime and then 6 months of eradication. So oral Septran you have to give for almost 6 months. Next slide. Remember, there will be adverse events because of Septran. It can cause Stevens-Johnson syndrome. It can cause myelosuppression. It can cause hemolytic anemia. It can cause rash. It can also cause hyperkalemia in patients who are having acute kidney injury or chronic kidney disease. Next slide. So this is all about IV Septran. Hope you know now where to produce Septran in clinical practice. And if there is any questions, I'll like to answer.
Yeah, from the forum, if anyone has any questions or queries, please feel free to ask. I think, sir, you have cleared all the doubts and all the, because in between, when the network was stuck up, you have already cleared the thing.
Yeah.
So we really appreciate and thank you so much for connecting with us. On behalf of Polen Healthcare, we would like to say thanks for your valuable time and putting the light on Cotrimoxazole on this. Thank you so much, sir.
Thank you. Thank you.
Thank you everyone for connecting.
Thank you, sir.
Thank you, sir.
Thank you, sir.